attention is critical to memory in the sense that one example of what I see as a general shift going on toward brain-based therapy in various schools is in CBT. The guy I mentioned earlier, John Teasdale at Cambridge, has he and some colleagues took up the problem of why there's such high recidivism, what to do about the high recidivism in major depressive disorder. If you have one episode of major depression, your chances of having a second are 2 or 3 times as high as controls, and every episode you have, your chances increase of having essentially a chronic disorder. So these guys were looking at how do we interrupt that, because this could well be a case of Heb, of neurons that fire together, wire together, of the brain learning how to be depressed. So they did 2 things. Siegel at the Zendel Siegel at the University of Toronto did a CBT study, CBT, and got a depressed cohort and gave half of them Prozac, the ones appropriately, and half of them just CBT, and he did imaging studies of both. And in the patients who were treated successfully with CBT, this is what really made me feel like I have got to learn more about this. I think it was kind of an idiosyncratic reaction. I was looking at the images from these successful CBT treatments, and it changed the brain. The brains are different of these people, pre and post. And all that happened was a conversation. And I'm not just talking about functional change, I'm talking about morphological change. That the brain can turn experience into biology. And that just totally rattled my cage. That's one of the most exciting things I have seen happen in my career as a psychotherapist. And remember that finding from the psychotherapy outcome studies that the therapist's attitude is a weighty factor. And I am really excited about this stuff, and I want to find out. I'm curious about it. I want to find out more. I want my patients to find out more about it. I want them to teach me about it. I want them to start finding out how this thing works so that they can take better care of themselves. One of the issues about attention is that moderate stimulation, it's like the attachment stuff in a way. What you want is moderate stimulation. That's what's most conducive to attending to something. Mindfulness, in a way, is a way of lowering the temperature to a point where you can really attend more to affects. So the second study that Teasdale did was actually with Zendel Siegel and John Kabat-Zinn. They used mindfulness along with CBT to see what they could do about this recidivism thing, and their results are brilliant. They've cut the recidivism in half. Given that the depressed cohort is the largest cohort in psychiatry, that 1 person in 5 in their lifetime will have an episode of major depression, 1 adult in 5. To be able to reduce that is a really stunning accomplishment, and we can understand that not in terms of Zen theology. I mean, if you prefer, you can certainly understand it that way. We can understand it in terms of Western biology. Fight-flight mechanisms were designed for action. They're not designed for either reflection, and they're designed to last 15 minutes to 2 hours. They're for the moment when you step off the curb and you weren't looking, and you just about get run over by a Harley Davidson and you jump back. They're designed for the moment when you come around the corner and you see the 8-year-old kid trapped under the wheels of a Volkswagen, and with superhuman strength, you can lift up the rear of the car and get the kid out from under it. Cortisol and adrenaline do amazing things, but they are not conducive to our best level of thinking. When stress is early and prolonged, you get a resultant you get consequences that are long-lasting and can be devastating. And it's part of our heritage from our evolution that we're able to think back, to reflect, to stay stuck on these highly charged, anxious experiments. Again, this is something I always share with patients, so that who are depressed and anxious, and I do use more of a mindfulness approach with them about this, as well as my traditional CBT and psychodynamic stuff around the normal course of a feeling is like a normal curve. Okay, it increases, it peaks, at some point it will subside, and it will go away, and you'll be on to something else. I heard John Kabat-Zinn talk about this recently, and he was making an analogy between mindfulness and driving. And he said, the two really have a lot in common, because when you're driving, you notice, you're paying attention. You better be paying attention. There's my store. My favorite store is having a 95% off sale. There's somebody in a short dress with a nice butt. But you don't stop and get out of the car. You don't get attached to it. You just notice. And if you do get attached to something, if you notice that you're going inside and you're not just paying attention to the next thing coming up, you form an attachment. Siegel says that what happens around that experience is that the part of the brain that we're talking about, which is probably the prefrontal cortex, the part that solves problems, that figures out how to do your 1040, that figured out how to register for this class, and you're thinking about what you're going to do for dinner tonight, the problem-solving part, when it gets directed at these emotional states, that for people who get depressed, the difference between people who get depressed and people who don't is that there's a kind of a bond that occurs at that point, and that intelligence is directed at an emotion, which should go like that, as if it were a problem to be solved. And then what you get is a prolongation, and sometimes, very often, an escalation of the feeling. It makes it last longer and go on and on. So teaching depressed and anxious clients not to let go, but to pay attention, and in particular to pay attention when their mind is getting into the game in that way, it produces psychopathology. In terms of the physiology of stress, a real important little item is this thing here called the hypothalamus. Lots of parts of the brain compete to influence the hypothalamus, because it's really the hypothalamus that controls the switches about whether we're going to go to the parasympathetic nervous system. That's what you use when you get turned on, or the sympathetic nervous system. That's what you use when you have an orgasm. The parasympathetic nervous system is about relaxing. It's about being cool. It's about being serene, enjoying yourself. The sympathetic nervous system is about arousal. It's about a response. It's about doing something. It's about getting ready. And so there's competition among these modules to get control of the hypothalamus. Again, this is just another illustration of the amygdala and hippocampus. I want to just go back and think a little bit more about brain-based therapy. I think you're probably getting the picture. For a couple of reasons, we have not formulated this as a technique. Where it's not particularly a school of thought. One of the reasons for that is that the finding from the psychotherapy literature, that approaching the relationship with a client, with another person that way, is not, it doesn't give you great purchase over not approaching it that way. It's wonderful to have tools and to think in an attachment-based kind of way about what would make sense for this person given who she is, given what my understanding about her is. But it's unlikely to be helpful to walk in. Someone comes in and says, I have bipolar disorder, so that they have in effect presented themselves as a disorder. And we are all set up, given the zeitgeist, to respond as if that's who we're talking to. And we have a protocol for dealing with bipolar patients, and that's what we're going to follow, and boom, we'll get a good outcome. Sometimes you do, sometimes you don't. You can enhance it significantly by looking at it, the person qua person. Our old friend Michael Lambert, after many years of research, has moved into a system that he calls outcomes management. And the essence of this is something that we've imported into our way of thinking about things. And basically what it involves is a more structured way of getting, of surfacing attachment, transferential attachment information from the client at the time. The way Lambert does it is he gives a questionnaire at the end of each session, very short, asks in very, very plain, non-medicalized English for the client to assess how they're doing in terms of the things that they came in for to see you about. And there are 3 questions at the end that ask about the alliance. We're doing this on a pilot basis at Kaiser, and the results, I have to tell you, are really quite startling. I mean, I am a typical white, somewhat arrogant male therapist who's been in practice for 30 years. I think I know my business. And I have been really surprised at how much I've learned from my clients about how frequently I am missing something from them about how they're doing. There's a question, do we talk about the things that are most important to you? But the thing that I typically get low marks on is in the alliance. And that question is, do you understand and agree with the treatment plan? I thought it was obvious. I thought people knew what psychotherapy was. I thought they understood why it works and what you have to do in order to make it work for you. And since I have used that information and coupled it with talking about the brain and making clear how the technique that I am using at that point addresses something that has to do both with the subjective experience, the psychological experience of the problem, and the biology of what's happening in the brain, the ratings go up, and so do my outcomes. This system allows you to look at, it's called evidence-based treatment, treatment-based evidence. Instead of evidence-based treatment, it's called treatment-based evidence. And so it allows you to tune up and change the therapy as you go along, which is so consistent with attachment. And that's how the brain gets made.